The first step in the operation begins with mobilization of skin flaps, either done sharply or with the electric cautery. Identification of perforators is critical. Preserving these perforators can be done, but routinely in complex reconstructions, the perforators will be divided with the electric cautery. Mobilization of the skin flaps does allow for fascial advancement, but frequently component separation techniques will be needed. The first step of the operation involves placement of a towel intra-abdominally to protect the viscera and to allow for abdominal wall reconstruction. Our hernia defect is visualized and component separations are then performed. First, using the non-dominant hand, the abdominal wall is grasped and pinched until the linea semilinaris is identified. This is initially marked, the edge of the rectus complex is noted, and then a fasciotomy using the electric cautery is performed, dividing the aponeurosis of the external oblique. Sharp dissection and the electric cautery are used to identify this layer, which is avascular in nature. We identify the internal oblique and note the orientation of the internal oblique muscle fibers. Dissection precedes cephalad, dividing the aponeurosis onto the chest wall. The musculotendinous portion of the external oblique muscle inserts onto the chest wall, and the muscular portion of this is divided. Further skin flap mobilization for adequate visualization is occasionally performed. Dissection precedes caudad, dividing this aponeurosis, which is very thin, and it's important to maintain the correct plane, as there should be fat and adventitia in this plane. Alice clamps are then placed onto the cut edge of the lateral external oblique aponeurosis, and the Bovie cautery can be used to dissect this plane very readily. Separation of these two layers of the abdominal wall allow for medial advancement of the rectus complex and for closure of complex ventral hernia defects. This is a relatively avascular plane, and we can note the external oblique muscle fibers being held up. Blunt dissection readily identifies this plane, and this can be performed even further to achieve greater advancement. This is a musculocutaneous flap, as the external oblique remains partially attached to the subcutaneous flap, and this helps with and facilitates perfusion to your skin flaps. The endpoint of dissection is identification of perforating intercostal vessels to the external oblique muscle. Division of the external oblique onto the chest wall is critical to achieve closure of large epigastric defects. This is done with electric cautery until the ribs are identified. We can see the dissected plane here, in which we have dissected the space between the external oblique and the internal oblique, preserving the segmental intercostal innervation to the rectus complex. This leaves a significant amount of tissue laterally and allows for the rectus complex to be advanced medially. A similar technique is performed on the contralateral side, again identifying the linea semilunaris by pinch